have next speaker now, Dr. Shruti. Please come. She's presenting an interesting case of ocular splinter in CI ops area.
Good morning, everyone. May I?
Yeah.
Okay. Good morning, everyone. My topic is on interesting case of ocular splinter in counterinsurgency in war scenario environment. So the ocular adnexal injuries, both combat related as well as accidental, are common during CIOPS and proxy war environment, and eyes are predominantly susceptible to serious injury from high velocity, tiny flying objects, which minimally affects the other parts of the body, but they cause grievous injury when it comes to the eye. So this is a case of ocular splinter in CIOPS area. A 25-year-old serving personnel sustained an injury to his left eye while firing in a unit area. Following injury, he noticed foreign body sensation, watering, and diminution of vision in the left eye. He was referred to the center where I was working. So on initial evaluation, anterior segment of right eye and everything was normal. The left eye visual acuity was 6/18 with no further improvement. The left eye showed 3.5 into 2 mm. This is the splinter situated with a full thickness scleral laceration sitting over the medial rectus. This is a CT scan, NCCT. It's a 6.5 mm metallic splinter abutting the medial rectus muscle. He underwent wound exploration, splinter removal, and primary repair under general anesthesia. This was the foreign body being removed, and this was post-surgical removal. And after that, after surgery, he was evaluated posterior segment. He had a peripheral retinal break and vitreous hemorrhage. He was referred for VR surgeon, and where he underwent barrage laser, and currently his visual acuity. Last time it was 6/9, and the next follow-up it was 6/6. So to conclude is the CIOPS injuries include both combat as well as exercise related injuries. The combat injuries, because it's a tiny object going into all the way back to the back of the eye, and can cause grievous injuries. So early referral, the main issue we face is the transportation of casualty from the site of injury to the referral center. The duration it takes for the patient to reach to me. So that plays an important role. There are times where they do get airlifted, and we will be able to intervene early. Depends on the grievous injury. So this patient was transferred early, and I was able to manage. So this is the case. Thank you. Any questions?
What was the duration between the injury, the presentation and the surgery?
Ma'am, 2 hours, ma'am. He reached in 30 minutes, and we routine general anesthesia evaluation, and then we took him for routine 2 hours.
The patient was taken up for surgery, wound exploration, and
Yes.
everything was done within 2 hours?
Yes, ma'am. He came, yes, ma'am, within 2 hours. Entire investigation. The trauma team is such that as soon as the patient is received in trauma center, the entire team is activated. The anesthetist, the radiologist, everybody comes as a team, and we take the patient immediately. That's how the things work.
Any specific precautions you took while removing the splinter? You said it was lodged into
Yes,
the
ma'am.
medial rectus muscle?
Yes, ma'am, medial rectus. I was cautious, and while resecting also, the peritomy also I was cautious, just looking for if I'm not touching the muscle insertion, and then I was able to remove it and was able to do primary repair completely.
So you didn't have to hook the muscle?
No, I didn't have to hook the muscle, ma'am. Because the one part of the splinter was visible outside, I could pull it out.